Hello everyone, welcome to Dr. Deepa's Learning Launch. Today we are here to discuss an interesting case, and every time I find an interesting case which has to be shared with you guys, I'll put it up as interesting case alert from Dr. Deepa's Learning Launch. So let's look at this. So this is a 66-year-old gentleman living in a scene 5 months, a right-sided nasal stuffiness for 3 months and feeling of a mass in the throat during and difficulty swallowing for about 1 month. There is no history of weight loss in this gentleman. So what you're able to see, you're seeing a congested oral mucosa, and the posterior nasopharynx is and oropharynx is showing a small mass which is hanging down from the nasopharynx to the oropharynx. The clinical pictures also included the nasal stuffiness. There was a growth in the nose, nasopharynx extending towards the oropharynx. The ENT surgeon had removed the mass and then sent for us on histopathology, and lo and behold, this was what it was looking like on histopathology, with multiple sporangia, mature sporangia, the immature sporangia and juvenile sporangia all in a single image. Every section had multiple of these sporangia, including the ones that were completely intact like these, and there were other sporangia also which was breaking up and releasing the spores. So this is, any guesses? What is this? What is this? So this is Rhinosporidiosis, and we will discuss in detail what you're seeing here. This is a mature sporangium. This is a juvenile sporangium. So this is a classical picture of Rhinosporidiosis. Rhinosporidiosis is a chronic infectious disease involving the mucous membranes, most often seen as a friable, reddish, polypoidal lesion in the nasal cavity and nasopharynx. Sometimes it can infect the eyes also, and it can it can hang down to the oropharynx like the classical case that we had seen. Although historically it is considered as a fungal infection, modern molecular studies have shown that Rhinosporidium seeberi belongs to aquatic mesomycetozoa group, placing it phylogenetically between fungi and animal types. So this disease is especially important in India because many cases are seen in the ENT and pathology practice, particularly in the rural population who are exposed to stagnant water, pond water. So the lesion often clinically mimics an inflammatory polyp, but histologically it is diagnostic because of the characteristic thick-walled large sporangia. One of the most important clinical teaching point is that despite chronic appearance, the lesion may bleed significantly because of its high vascularity. The exact route of transmission is not fully proven, but epidemiologically strongly there is a suggestion of an inoculation through water exposure, especially in pond bathing population. The organism generally enters through a small mucosal aberration, especially in people who pick on their nose. Once inside the subepithelial tissue, the endospore enlarges and develops into a mature sporangium, the image of which we just saw in histopathology. As the maturation proceeds, numerous daughter endospores develop within the thick wall. Eventually, the sporangium ruptures and releases the endospores into the adjacent tissue, causing a local spread and recurrence. So this explains why incomplete surgical removal often leads to good recurrence rates in these conditions. To understand the clinical features, I would like to put it this way. The patient usually presents as a unilateral nasal obstruction and recurrent bleeding from the nose. The lesion is often described as a strawberry-like mass because of multiple white dots that may be visible on the surface, which represents the mature sporangia underneath the epithelium, which is thinned out. So these white dots are clinically significant because they correlate histologically with this mature sporangia. The lesion is usually attached to the inferior turbinate or lateral nasal wall. Occasionally, the lesion may involve the conjunctiva, oral cavity, larynx, urethra, or even genital mucosa. Grossly, rhinosporidiosis can be mistaken for an inflammatory polyp. However, a careful observation often reveals these small whitish pinhead dots representing an underlying mature sporangium. The lesion is usually soft, friable, and bleeds easily during excision. The gross features are highly important for the surgeons, and the same thing would be translated into histopathology as well. Histology is pathognomonic. The histopathology shows an important diagnostic feature, which is thick-walled spherical sporangia at various stage of maturation seen at one slide itself. So these sporangia are present in subepithelial stroma. Different sizes indicate different developmental stages, and the mature sporangia can contain hundreds of endospores. The wall of the mature sporangium is usually thick, eosinophilic, and sharply outlined. The feature immediately differentiates rhinosporidosis from the other fungal infections. This is a whole slide image of one similar case. You're able to see here multiple sporangia of various stages. This is a mature sporangium. These are juvenile sporangia. So this is a sort of emptied out sporangia where the spores have come out. And surrounding this, you're able to see this chronic inflammatory infiltrate everywhere. So you're seeing lymphoplasmacytic infiltrate here. You can see some of the eosinophilic infiltrates also. In case there is a sporangium that's broken up in the surrounding the area where there is a sporangium that has liberated the spores, there you can see a dense neutrophilic infiltrate also. A very important point is that all developmental stages can be seen in a single section in rhinosporidiosis. Small trophic forms can be present early in the development. So these are small trophic cysts which are present early in the development. And as the organism enlarges, the daughter spores from inside produce the mature sporangium with a central sort of a clustering. So these large spores, when they rupture, they release the spores. So these are the various stages that you can see. And usually there are fresh lesions nearby due to auto-inoculation. Once these spores are released, there is again an auto-inoculation in and around the surrounding area. You will have repeated infections. The type of inflammation which surrounds these spores basically depends on the sporangial integrity itself. If there is an intact sporangia, there is little reaction around it, while a ruptured sporangia can have an acute inflammatory response around it, which means neutrophils accumulate surrounding a spilled endospore. Sometimes multinucleated giant cells also can be surrounding these cysts. Granulomatous inflammation is also not uncommon. So in our section here, what are we seeing? This is around an intact spore actually. So around the intact spore, what was found was like these plasma cells you're seeing here. These are lymphocytes, some epithelioid macrophages here and there. There are eosinophils as well. So you see a mixed inflammatory infiltrate in case of an unruptured spore, but in case of a ruptured spore, you'll see an acute inflammatory response. In the sense, there'll be plenty of neutrophils surrounding the ruptured spore. Special strains are generally not required for the diagnosis of rhinosporidiosis because the appearance on histopathology is very classical, but there is a role special strains can play, especially if the morphology is distorted by a friable tissue, or when you're getting a very small amount of tissue which hardly has any sporangia. So in these cases, PAS highlights the endospores strongly. So if you're missing out on small endospores, the PAS can pick it up. Mucicarmine positivity is especially important because it helps in distinguishing rhinosporidiosis from coccidiomycosis. So the wall itself also stains positive, which is highly characteristic of rhinosporidiosis. So this is the role of special. The close mimicker of rhinosporidiosis is coccidiomycosis, which may mimic rhinosporidiosis histologically, but the size of the sporangium is very small. This is a histopathology image of coccidiomycosis. We are able to see these small sporangia, and there's surrounding granuloma formation right around it. You're seeing macrophages, some neutrophils, and lymphoplasmacytic infiltrate, which is surrounded, and there's a giant cell as well. So the major difference is the size of the sporangium, which is much smaller in coccidiomycosis, and also mucicarmine is a stain that can be used, which is not positive in coccidiomycosis, but it is positive in rhinosporidiosis. And another differential is the sinonasal papilloma, which can show cystic spaces, but that lacks the thick wall of the sporangia. So sometimes when the sinonasal papilloma has these small areas which are empty and cystic, they can mimic the appearance of a rhinosporidium. Medical therapy in general is highly ineffective for rhinosporidiosis. A complete surgical excision with cauterization of the base is essential because the released spores can reimplant locally. Recurrence usually results from an incomplete excision or an intraoperative excessive spillage. So the follow-up of a patient who has been successfully surgically treated is very important. You cannot just let the patient go after a week or two of follow-up. You need to follow him up for quite some time because there is a local spread that is possible. The recurrence rate is about 10% after a successful surgery as well. So the key features for exams and for reporting is the simplest memory clue, which is large thick-walled spherical structures filled with spores in sinonasal mucosa. It is rhinosporidiosis, and this diagnosis should be immediate if you see a histology like the one that I've shown you, which includes different maturation stages, large thick-walled cysts, numerous internal spores, and mucicarmine positivity. So just to recollect, these are the large mature sporangia, these are immature, and these are the juvenile sporangia. All of them you can see in a single histological slide. So thank you for your time. For many such interesting videos, stay tuned to www.drdeepaslearninglaunch.com, and this is Dr. Deepa signing off for today. Bye bye.